Hi guys, welcome back. The next topic we're studying is rheumatic fever and rheumatic heart disease, and I'll be discussing updated Jones criteria with you. In fact, most of the time in the exam, they love to ask about these updated criteria, both the major and the minor ones that I'll explain to you in detail. First, we have a look at the baseline information for this topic. It's an example of type 2 hypersensitivity reaction. Well, the organism responsible will be group A, beta hemolytic streptococcus. This can be responsible for either causing skin infections or contributing to recurrent sore throats. And when it comes to rheumatic fever and if our development of rheumatic heart disease, it is recurrent sore throats that are relatively more common etiology wise. The patient is going to be 5 to 15 years of age and he has these recurrent sore throats and keeps on coming to your clinic on a regular basis. Now, because of this recurrent sore throats, obviously because there's a bacteria involved, there would be antibodies produced against it, and the antibodies in this case will be then neutralizing the bacteria. So let us hypothetically take this rectangle to be the representation of group A beta hemolytic streptococcus, and on the surface of this are the targets of these antibodies. You are aware from your microbiology class that this bacteria will be having M protein on its surface, and the bottom line is that this antibody is like a laser guided missile. Like the missile locks onto the target and destroys the target. Similarly here, this antibody is supposed to latch onto this target and help in destruction of the bacteria. But the bad news is that this antibody actually will cross-react with certain components of connective tissue whose chemical structure can be identical to that of M protein. I am teaching you regarding type 2 hypersensitivity reaction, where the antibodies will obviously try to attack the bacteria, but they might start attacking self tissues also. So the first MCQ that we're going to discuss here from the exam perspective will have a microbiological overlap also. The question in the exam said that what is the name of the antigen and where is it present, whose chemical structure is same as that of M protein and therefore the antibody is cross-reacting. So we need to understand that this component that I'll discuss with you will be present everywhere in the body. I can call it omnipresent. This component of the connective tissue is technically called as N-acetyl glucosamine. The point to be understood is that the antibody is getting confused because both of these antigenic targets will look the same to it. So it will start attacking the self-human body, and this results in development of creation of Ashkoff nodules. In fact, lots of time they can correlate this with pathology as well. So no big deal. They can give the exact image which is given in Robbins for Ashkoff nodules, or if they might even zoom into that view of Ashkoff nodules, you will be able to notice regarding these particular cells which are called as Anishkov cells. Now the problem with these Anishkov cells per se is that one, they have this peculiar terminology. Why they call it peculiar is because the nucleus of this cell per se will look like a caterpillar, the serrated appearance. So the pathognomonic feature of this condition is Anishkov cell, which is also taught as caterpillar cells per se, and the histopathological image of Ashkoff nodules is obviously to be read from the pathology domain. And in fact, one or two choices in the MCQ can be these details that are taught in the paraclinical subjects as well that I've highlighted. Two important carry home messages from this slide are N-acetyl glucosamine is the target against which the antibody will cross react, and caterpillar cells / Anishkov cells are going to be the pathognomonic feature of this disease. Now let's look at how the disease will evolve. And per se guys, connective tissue is everywhere, no? I mean, connective tissue will be in the heart valves, it will be in the brain, it will be in the skin, subcutaneous tissue. So that is why you get neurological features like chorea. There can be endocarditis component developing, or there could be subcutaneous nodules developing, and even to the level that even the joints can be involved. So you could either be having arthritis or even arthralgia. One of the very prominent updates that I want you to remember for Jones criteria is that now even subclinical carditis, what I mean by subclinical carditis is echocardiographic findings are also a part of the major criteria. The most of the criteria are almost the same, just a finer nuances are there which I'll explain to you in the form of low endemic area, high endemic area zone. Low endemic area would mean, like for example in America, where development is more, so sore throat incidence would be lesser. And in our country, because of overcrowding, because of our population, the incidence of sore throats will also be more, and incidence of rheumatic fever will also be more. So India per se will be a high endemic zone. So they have subdivided this into low endemic and high endemicity, which I'll explain to you as we progress. But one of the most important things that I want you to remember is that echocardiographic criteria have also been added to the major criteria. This is 2015 update, because last time these criteria were updated were way back in 1992-93, but then the 2015 update is the one which is usually asked by the examiner. We will first focus on the major criteria. That will take me some time to explain, so please be patient. And one of the important ones to be remembered is the carditis component. They can be pericarditis, myocarditis, endocarditis. Any of the three layers of the heart can be involved. And obviously, if it is endocarditis, that is when the valvular lesions would be occurring. Now, what is highlighting currently is that why do you want to wait for valvular lesion like mitral stenosis or mitral regurgitation to develop and then say that, okay, you are having rheumatic heart disease? He says that even if you are able to identify the valve inflammation by echocardiography, you can actually be having even a subclinical carditis. What I mean by subclinical carditis is, let us take this to be a representation of any of the heart valves, because mitral is the one that is usually involved. So what I'm showing in this diagram is inflammation of the valve cuffs. You see, in this condition, Ashkoff nodules can be in the superior surface of the heart valve, inferior surface of the heart valve. But yes, Ashkoff nodules are found in substantially high area, concentration in this area where the valve cuffs are touching each other. So the tip of the valve which is touching one another is called as commissural ends, or you will just read the technical word valvulitis. The importance of this valvulitis is that because of the inflammation present here, the valve cusp may not be able to approximate properly, and there might even be leakage of blood. If the amount of leakage of blood is very less, the murmur may not be appreciated. You see, when you are in a busy OPD and with lot of noise and cacophony in the background, there's a high probability that in a busy OPD you may not be able to appreciate a murmur because of the background noise or the ambient noise. So he's saying that why do you wanna miss out a case? Just because you were not in a proper setting, if echocardiography can pick up this valvulitis, then even then, without or the presence of mitral stenosis, mitral regurgitation, or valvular lesion, we can say it is rheumatic heart disease, because after all, this is the starting of the disease. Once the disease will evolve, that is when valvular lesions will develop. Our objective as a doctor is early identification of the disease, and that is why I'm highlighting this particular domain that they love to ask. Subclinical carditis / valvulitis is also now a major criteria. I will now be mentioning regarding clinical carditis also. There can be development of rheumatic pericarditis. Now let us see how rheumatic pericarditis will evolve. This is the same kid, 5 to 15 years of age, recurrent sore throats. And today this child is having severe episodes of chest pain, which is present at rest also. Now maybe a 5-year-old child may not be even able to tell you that I'm having chest pain. So all he is doing is crying and he did not go to school today. In those circumstances, when this child is brought to you, obviously crying child is very difficult to manage, but somehow you were able to calm down the child, or the mother was able to calm down the child. And when you are auscultating the kid, you will be hearing a scratchy sound in the chest. This scratchy sound of the chest is called as pericardial friction rub and can be easily differentiated from pleural rub, because pleural rub is related to breathing, but pericardial friction rub is independent of breathing per se. This is going to persist even on breath holding. The scratchy sound on the chest will persist on breath holding, whereas pleural rub is mainly present on inspiration. Now, once you're able to differentiate that the scratchy sound that you're hearing is a pericardial friction rub, you want to be sure that is this an artifact? Is that something related to a stethoscope that is causing this, or is it actually a genuine sound that you're hearing? You can definitely supplement this by doing ECG, and you were surprised because this child was having a global, I'm saying global because pericarditis will be all around the heart. So the child will having a very characteristic ST elevation with a concavity in upward direction. So that definitely gave credibility to your diagnosis that this child with recurrent sore throats is having now a rheumatic pericarditis. The main message is pericarditis will contribute to chest pain due to irritation of the phrenic nerve, and for the treatment of this condition you are mainly gonna use steroids. Do not answer aspirin. We use aspirin mainly for management of the arthritis component, but for the chest pain component, the inflammatory component, we shall be using steroids. There is also a possibility that the Ashkoff nodules might be damaging the myocardium, and therefore you could have a rheumatic myocarditis. Now, if it's going to be a myocarditis, then the bad news is it can even trigger a acute congestive heart failure. Whenever there's going to be a heart failure, the heart will dilate, and this can contribute to development of a functional, I'm saying functional because at the moment there is no fundamental difference to or damage to the valve leaflets. It is early part of the disease, so only because the heart is dilated, the tricuspid annulus will dilate, the mitral annulus will dilate, and therefore there could be a functional MR or functional TR developing in the patient, and this functional MR will worsen the pulmonary edema component. Therefore, in rheumatic myocarditis, in the first presentation of rheumatic myocarditis, because he's having acute pulmonary edema, Therefore, we will have to use a couple of drugs that I've highlighted, that is LMNOP, Lasix, morphine, oxygen, and positioning. I've discussed that even in congestive heart failure component that we will be using Lasix, that is a diuretic. Why do you use morphine? Because morphine causes shunting of blood from pulmonary to systemic circuit. In simple English, it means that the blood will be shunted away from the lungs per se, so the pulmonary edema component will reduce. Nitrates, why? Because nitrates reduce preload as well as afterload, so they are gonna reduce the load on the heart. Oxygen to obviously give some fuel to the starving muscle. And then positioning is important because all patients of congestive heart failure, the head should be higher as compared to the legs. Why? Because if the legs are relatively lower, then the venous return to the heart will be lesser, so the load on the heart will also be relatively lesser. When it comes to myocarditis, it can also contribute to ST segment changes, but they're relatively non-specific ST segment changes. You see, I want to highlight that if it is going to be rheumatic pericarditis, then there will be definitely a ST segment elevation, which is concave upward, and this ST elevation will be present in almost all the leads except one, that is AVR. You are anyway familiar from the ECG discussion that AVR is always going to behave opposite of the standard leads. In AVR P wave, the first wave of the ECG and the last wave of the ECG is upside down. It is negative. So you will get a ST depression, that is a mirror image. Myocarditis can also have non-specific ST segment elevation or even non-specific ST segment changes. So I'm not commented on the ECG finding per se because it is non-specific. Now, most examiners are very interested in clinical carditis because they want to see your knowledge of rheumatic endocarditis. And because of this endocarditis component, the valvular lesions will be developing. Patients could be having, it can either be any one of these or all three of these. As they teach you in pathology, multiple layers of the heart can be involved simultaneously as well. For endocarditis, I would like to subdivide the discussion into which valve is commonly involved. You very well know that is going to be mitral, but I'll put up a question before you: which valve is usually not involved or rarely involved in rheumatic etiology? Then we will talk about what are the common valvular lesions that are seen. You are anyway aware of mitral stenosis developing in the patient. And lastly, I will speak regarding which surface of the heart valve is involved per se. That is going to be the commissural ends. Now, when we talk about the valve involved per se, as I've highlighted, the most common valve involved is mitral, but the question was asked vice versa: which heart valve is usually not involved in rheumatic endocarditis? That is going to be the pulmonic valve. In contrast, when it comes to valvular lesion per se, in adults, it is definitely gonna be mitral stenosis. But if he gives you a question in pediatrics, he mentions 5-year-old boy diagnosed with rheumatic heart disease, which is the commonest valvular lesion, your answer will be mitral regurgitation. Please remember, for pediatric age group, it is gonna be mitral regurgitation. For adults, it's gonna be definitely mitral stenosis. In lots of cases, it can be concomitant also. Now, MS with MR can also be there. Now let us look at how the examiner will play around with words. There is a distinct possibility that in some questions he might say the word rheumatic active carditis, or he might say rheumatic carditis. Now look at one word that will change the entire domain. What I mean by active carditis is the initial presentation of the disease. That's a pediatric presentation. So the answer will be mitral regurgitation. And if he says plain carditis, it means a chronic presentation, long-term presentation. That's going to be mitral stenosis. The same information which I mentioned superiorly has once again been discussed, but in a different way. You can see that the word active per se is making one word of a difference. I mean, when you're reading a question fast, no, there's a high probability you might miss this word and end up it as answering it as mitral stenosis. So be very careful with the terminology that you're reading. And when it comes to rheumatic endocarditis, pediatric, early presentation active disease is MR, later presentation is MS, and then both of them could be involved simultaneously as well. As far as the surface involved is concerned, I've already explained that to you, but I'm going to discuss another domain here. So listen to this representation once again. What I said was that Ashkoff nodules could be involving superior surface of the valve, inferior surface of the valve, but max involvement is seen of the tip of the valve. So in pathology, they will use this classical term, commissural end involvement is seen in patients of rheumatic endocarditis. Because of this, the coaptation, the valve leaflets should be touching each other tight. In this case, the coaptation is not proper, so there can definitely be leakage of blood between the valve leaflets. As a result of this leakage of blood, there would be two things that would be happening. One is again from pathology domain, because this blood will go and it will strike the left atria per se. So you will always read regarding McCullum's patch. It is itself a question. No, McCollum's patch is encountered in the free wall of the left atria. I want to highlight that again, free wall of the left atria.